You're listening to ReachMD, and this is Advanced Treatments and Innovations from Mayo Clinic. Here's your host, Dr. Matt Birnholz.
Cardiac surgeries are complicated procedures that call for a sophisticated skill set. But cardiac reoperations are even more complex and require a highly advanced set of surgical techniques. And with more patients than ever before going back for reoperations, what techniques can we apply to help improve outcomes for these surgeries? Welcome to Advanced Treatments and Innovations from Mayo Clinic. I'm Dr. Matt Birnholz, and joining me is Dr. Juan Crestanello, Chair of the Department of Cardiovascular Surgery at Mayo Clinic in Rochester, Minnesota. Dr. Crestanello, welcome to you.
Thank you.
So let's dive right into this subject of complex cardiac reoperations. Now, what are the risks associated with repairing the heart a second or even a third time? And in that vein, can you just tell us about the mortality rates and outcomes associated with these operations?
In general, patients who require reoperations are older and they have more comorbidities. In addition, the anatomy around the heart changes after the first operation, and there's the development of more scar tissue that leads an increased risk for reentry on the chest. For example, the heart or the great vessels that leave the heart can be behind the sternum, and that increases the risk of reentry on the chest and as well as the risk of bleeding.
And I take it that increases the mortality rates and outcomes associated with these operations. Is that true?
Yes, that's correct. Here at Mayo, we do more than 300 reoperations per year. The majority of them, about 70%, are first-time reoperations, and about 30% are second, third, fourth, or more time reoperations. Many of the reoperations that we perform, we can do it with morbidity and mortality that are similar to the first-time surgery. But overall, if you take all reoperations, the risk of mortality is about 6%.
So let's dive into that a little bit further. What, from your experience, makes a reoperation surgery so challenging? You talked about scar tissue, but how do you determine whether or not a patient is even going to be a good candidate for this procedure?
When we evaluate the patient's candidacy for surgery, the two things that we evaluate are the overall physiological condition of the patient, and that involves the age and comorbidities, and particularly for the reoperation, the anatomic factors that could potentially make the reoperation and the reentry on the chest more challenging. That includes, for example, having the aorta or other vessels immediately behind the sternum, the right ventricle or previous bypass grafts immediately behind the sternum, the previous history of mediastinal radiation. Other factors is the number of reoperation. It's not the same doing a first-time reoperation versus a second, a third, or a fourth, or subsequent numbers. The higher the number increases the risk. And also there's some particularly lesions that, like aortic insufficiency or patients who had poor ventricular function, that makes the risk of reoperation higher.
So that brings up one of the natural questions that I'm sure some of our listeners are wondering, Dr. Crestanello, and that's whether reoperations should be perceived as necessary at all. What factors are at play here in terms of making the decision to do a reoperation?
Like every decision that we made in cardiac surgery, the three factors that are in play is, number one, the type of lesion, either a valvular lesion, coronary artery disease, or aortic aneurysm that demands the operation. Number two, the repercussions that lesion had in the heart, in the function of the heart, as well as in the symptoms that the patient has. What is the natural history of that lesion if we don't do anything versus we operate? And then once we have that information, the second step is to analyze what are the comorbidities of the patient and whether the patient will be able to tolerate the surgery. And number three is to analyze the technical aspects of the operation. And here is where reoperations are particularly challenging. And we use a multi-imaging modality to assess the safety of the reoperation before the surgery. We do CT angiograms of the chest and the abdomen, and that allowed us to identify the location of the different cardiac structures in relation with the sternum and assess the safety of re-entry on the chest and plan the surgery accordingly. Based on those findings, we can decide that it is the going through the sternum is not the ideal approach. We may decide to do the operation going through a thoracotomy through the side, either through the right or through the left side. And also we may decide to place the patient on cardiopulmonary bypass before opening the chest, and that is accomplished normally through the femoral artery and vein.
That's excellent. So these more precise diagnostic workup procedures and tools and techniques are enabling you to have a better cost-to-benefit ratio analysis for whether to proceed with these procedures.
Yes.
Well, for those just joining us, this is Advanced Treatments and Innovations from Mayo Clinic. I'm Dr. Matt Birnholz, and today I'm speaking with Dr. Juan Crestanello about the key considerations underlying complex cardiac reoperations. So, Dr. Crestanello, I want to switch gears and explore some of the techniques that have been developed in response to these challenges you talked about around cardiac reoperations. What kinds of techniques or approaches have come onto the scene for you?
Well, as we discussed before, number one is the planning of the reoperation, and that's the main step to assure a safe re-entry on the chest. And as we just discussed, we accomplish that by performing a CAT scan of the chest that allow us to precisely determine the relationship between the sternum and the cardiac structures and plan the operation accordingly. In addition, the placement of patients on cardiopulmonary bypass through the groin vessels before the opening of the chest add safety to that surgery.
And Dr. Crestanello, I'm particularly curious, given the high volume center that you're at, performing over 300 operations for cardiac reoperations, as you put it. At what point would other clinicians in this therapeutic category consider making the call to refer a patient to a high volume center such as yours for reoperative repair of the heart?
Well, I think that the reoperations are challenging reoperations, and we are experts in the field. Really, any reoperation should be conducted from my point of view on a center that has expertise to deal with the reoperation as well as the complications of the reoperation, but particularly second, third, and higher number of reoperations should be done in certain centers of excellence where the whole team is trained to deal with this type of cases.
And I'm sure this is somewhat intuitive, perhaps obvious to some of our listeners, but it almost goes without saying, but needs to be said, that high-volume centers in other therapeutic categories for surgical procedures, the outcomes are far better than places that are not as steeped in performing these procedures. I assume the same holds true for cardiac reoperations. Is that true?
Yes. Our outcomes are far superior than what other centers report.
So then, Dr. Crestanello, I want to try looking ahead at any developments that are on the horizon with the potential to really improve cardiac reoperations. What do you think we should keep an eye out for, and what's going on over at Mayo?
Well, the first step is to try to avoid the reoperations. And clearly, there are several reasons for reoperations. One of them is deterioration of previous valves that had been placed, developing of new diseases in other valves or other structures of the heart. So it is important that once one is diagnosed with a cardiac problem that requires a cardiac surgery, after that initial surgery, the adequate secondary prevention is performed. So strategies to prevent infection or thrombosis of the valve, and also monitoring for early deterioration of the heart function or developing of new lesions in the heart is very important, because it is not the same to operate at a stage and at an early stage of a certain cardiac lesion that doing a reoperation when that lesion has had significant repercussions on the heart function or in other parts of the body. So the prevention is one important consideration. Number two is the consideration for other type of procedures that like minimally invasive procedures or robotic procedures that can, in selective cases, done or during for reoperations that allow us to make those procedures less invasive and less risky. And now in the horizon is the transcatheter procedures for treatment of deterioration of prosthetic valves. And the transcatheter procedures allow for the replacement of some type of valves percutaneously rather than having to open the chest.
And do most of the minimally invasive procedures for cardiac reoperations center on valvular operations, or do they also extend to other aspects of cardiac function?
No, there are, in addition to reoperations for valvular heart disease, there are reoperations for coronary artery disease, reoperations for aortic aneurysms, reoperations for other new lesions. I mean, somebody can have an initial operation either for coronary artery disease or aortic valve disease, and now has developed mitral valve disease or tricuspid valve disease or an ascending aortic aneurysm that requires a reoperation.
So, Dr. Crestanello, before we close, let me just open the floor to you for any parting thoughts that you want to convey to our audience regarding cardiac reoperations and the evolution of these procedures and techniques over time, coming from your vantage point over at Mayo Clinic.
Well, I want to reassure the patients who require reoperation that here at Mayo we have the expertise to provide care for their complex heart problems. We have a multidisciplinary team that consists of surgeons, cardiologists, anesthesiologists, critical care nurses, nurse practitioners, who help us to put the anxiety associated with the problem that requires a reoperation at ease and give you the best outcomes available in the world.
Well, with those thoughts in mind, I very much want to thank my guest, Dr. Juan Crestanello, for joining me to share new thoughts on complex cardiac reoperations and the pathways to improve care. Dr. Crestanello, it was great having you on the program.
Thank you again.
You've been listening to Advanced Treatments and Innovations from Mayo Clinic. To access other episodes of this series, visit reachmd.com/Advanced Treatments Innovations Mayo Clinic, where you can be part of the knowledge.